All right, let's talk about postpartum hemorrhage, or PPH. This is, without a doubt, one of the biggest emergencies you'll face in obstetrics. Getting a handle on this topic isn't just about acing your exams, it's about knowing exactly what to do when every single second counts. So in this explainer, we're going to break PPH down into a super simple, high-yield framework that you can take with you into any clinical setting.
Okay, let's start with a classic clinical puzzle. Imagine you're in the labor room. A patient has just delivered and she's bleeding a lot. Your first instinct is to put your hand on her abdomen to check the uterus, and yep, it feels hard, well contracted like a cricket ball. But the bleeding just keeps coming. So what's going on? This is a really crucial diagnostic question, and don't worry, we'll have a clear answer for you in just a couple of minutes. So, first things first, what even is PPH? Before we can jump into managing this emergency, we need a clear, practical definition. Let's get that sorted out right now.
So, PPH really has two main definitions. You've got the quantitative one, which is mostly for studies and statistics. That's a blood loss of more than 500 ml after a vaginal birth. But let's be real, in an actual emergency, you're not going to stop and measure the blood. That's why the clinical definition is so much more practical. It's basically any bleeding that starts to make the patient unstable. Her pulse is climbing or her blood pressure is dropping. The real takeaway here is to forget the number and focus on the patient. How is she doing? That's what matters.
And just to put that 500 milliliter number in context, take a look at the average blood loss for different deliveries. A normal vaginal delivery is right around that 500 milliliter mark. But a C-section, that jumps to a liter, so 1,000 milliliters. And if it's a cesarean hysterectomy, you're looking at 1,500 milliliters. This just helps you understand what's considered normal versus what's truly excessive bleeding in different situations.
Okay, so what actually causes this scary bleeding? Well, thankfully, there's a fantastic and really easy to remember framework for this. It's called the 4 T's, and honestly, it's the absolute cornerstone for figuring out and managing PPH. Let's dive into it.
And here they are: tone, trauma, tissue, and thrombin. Now, this isn't just a random mnemonic to memorize. It's a logical pathway. You should literally run through these 4 causes, in this exact order, every single time you're faced with PPH. Let's break down what each one means. First up is T for tone, and this one is the big one. It accounts for about 80% of all PPH cases. An atonic uterus just means the muscle of the uterus isn't contracting down after delivery. See, after the placenta comes out, it leaves all these open blood vessels. The uterus is supposed to clamp down hard on them, like a natural tourniquet, but if it stays soft and boggy, those vessels just keep bleeding. It makes sense then that things like having a big baby, twins, or really long labor increase the risk. They basically tire the uterine muscle out.
All right, on to the second T, trauma. This covers most of the other 20% of cases. And this right here is the answer to our starting question. If the uterus is firm and contracted, but your patient is still bleeding heavily, you have to suspect trauma. This means there's a tear somewhere, a laceration in the cervix, the vagina, or the perineum. This often happens after a tough delivery or one that needed forceps. In the worst-case scenario, it could even be a uterine rupture. This is the absolute key difference to remember. A boggy uterus means tone. A firm uterus means trauma.
The third T is for tissue. This is all about retained products of conception. So if a little piece of the placenta, or even just a big blood clot, gets left behind inside the uterus, it acts like a physical barrier. It literally stops the uterus from squeezing down completely and evenly, and that leads to more bleeding. This is exactly why it's so important to carefully check the placenta after it's delivered to make sure it's all there.
And finally, our fourth T is thrombin. This is the least common cause, and it refers to a coagulopathy, basically a problem with the blood's ability to clot. The patient might have a known bleeding disorder, or it could be something that developed during pregnancy from complications like a placental abruption or severe preeclampsia. In these situations, even if the uterus is contracting and there's no trauma, the bleeding continues because the blood itself just can't form a clot.
Okay, so knowing the causes is one thing, but what do you actually do? Let's move on to management. We're going to build a step-by-step plan, and guess what? It's guided by that same 4 T's framework.
These are the first things you do, and they're lifesavers. First, shout for help. PPH is a team sport. While your team is on their way, you get to work. Palpate the uterine fundus. That one move immediately tells you if you're likely dealing with tone or trauma. At the same time, you've got to get 2 large IV lines in, start fluids with oxytocin to help the uterus contract, and send off blood for cross-matching and to check for any clotting problems. All this has to happen pretty much at once.
Now this table, this is pure gold for your exams. It perfectly summarizes the difference between the 2 most common PPH causes. If that uterus is soft and boggy, the problem is tone. Your immediate action? Uterine massage and giving drugs called uterotonics to force it to contract. On the other hand, if the uterus is firm and contracted, the problem is trauma. Your job then is to carefully and systematically look for a tear in the genital tract and stitch it up.
So what do you do for an atonic uterus that's not responding to massage or drugs? You use bimanual compression. You make a fist with one hand and place it inside the vagina, pushing up against the front wall of the uterus. Your other hand presses down firmly from the abdomen. You're literally squeezing the uterus between your hands to physically compress those bleeding vessels. This is a critical move that buys you time while you get other treatments ready.
And what if you think the problem is tissue? Well, if the placenta is stuck or you think a piece is missing, you have to perform a manual removal. This means you carefully slide a hand into the uterus, find the edge of the placenta, and gently separate it from the uterine wall. It's a delicate procedure, for sure, but you have to get the uterus completely empty so it has a chance to contract properly.
All right, we know how to manage PPH. Let's wrap up by talking about the best-case scenario, how to prevent it from happening in the first place.
So can we prevent it? Yes, to an extent. The single most effective thing we can do is something called active management of the 3rd stage of labor, which slashes the risk of PPH by a massive 60%. Of course, good prenatal care to treat anemia and making sure high-risk patients deliver in a fully equipped hospital also helps. But, and this is a huge but, most of the time PPH happens to women with 0 identifiable risk factors. What does that mean for you? It means you have to be ready for PPH at every single delivery. No exceptions.
Okay, let's bring it all home. We're going to do a super quick, rapid-fire recap of everything we've just covered. These are the absolute must-know points for your exams and, more importantly, for your clinical practice.
First, the 4 T's. Learn them, live them. Tone, trauma, tissue, thrombin. Second, tone is number 1, causing 80% of cases. Third, if that uterus is firm, but the bleeding won't stop, your diagnosis is trauma. Fourth, your very first action in management is always to palpate the fundus. And finally, for prevention, active management of the 3rd stage of labor is your best weapon.
And I want to leave you with this one last thought because it's so important. When you're facing a postpartum hemorrhage, your most powerful diagnostic tool isn't some fancy lab test or an ultrasound. Your first move is with your hands, not with a pen. Feel the fundus. That one simple action will put you on the right track to saving a life.